We have an extra special treat right now. We have Dr. Rossi in from New York, who is the director of CAR-T and stem cell transplant at Mount Sinai. So it's a really extra special treat that she's here with us today to be talking about supportive care in multiple myeloma. So welcome, Dr. Rossi.
Thank you. It is very nice to be here, and it is actually my second time. I did speak in Montreal a few years ago, so I look forward to getting to know the rest of the country, ready for next invitations. And I've had the other speakers set the stage so beautifully, so now I know you are all experts. You've done Myeloma 101. I'm pretty sure that went into like 104, and now clinical trial experts, so you have all of the data. And I get to step back and get more into nuts and bolts and have to thank Donna Catamero, who is one of your experts. So please, if you have questions on my talk, save them for her, who really is, I think, many times as physicians and academic scientists, we get really caught up with all of that data and the new thing and that molecule and the things that Dr. Cole beautifully animated for us. But the day-to-day, I think, is still probably the most important. And the number of patients I have had say, like, the flu is worse than cancer, which sounds absurd, but really it's affecting their day-to-day so much more. Because I think someone had mentioned earlier, myeloma is kind of invisible. And I have a number of patients who have actually gotten upset with me because they said, I would never know I have this if you didn't keep reminding me. I was like, no, we're here to celebrate the remissions we've gotten, you know? So really a lot of background. I had started with sort of a review on what is myeloma, but again, now that you all know, myeloma is considered one of the blood cancers, but it really is a blood factory cancer. So it's there in the bone marrow, and Dr. Joe did highlight, we do need to go into the marrow. We're working on getting better ways of studying it, but is where our happy, super excellent plasma cells start to misbehave and start to multiply, and in multiplying, take over the space that has normal blood cell production and make this antibody that then floods the blood and causes trouble. So even though we mostly think of it as a blood cancer, our focus tends to be kidneys and bones and immune system. And so this is, I think, hopefully going to encompass all of the bits. And he talked about the CRAB criteria. This is really the manifestation, right? How does myeloma show up? As the cells take over the space and you become anemic, so less red blood cells, less oxygen, then I think of red cells as trains, not trucks, but I concede the point. You don't have all of that oxygen getting where you need, you feel fatigued. The white blood cells can't do their job. That's that increased risk of infection. And for a while, we actually expanded CRAB into crabby because infections were sometimes a way we would catch the myeloma. Similarly, the bone can be damaged as these cells sort of elbow their way out of the marrow and into the bone. So bone dysfunction, and then in so doing, leaking that calcium out of the bones into the blood, that high calcium level. And both the high calcium level and the proteins all can cause damage to the kidneys. And that usually also contributes then to fatigue, and sort of everything feeds into itself. So these are the symptoms due to the myeloma. A little bit later, we'll talk about all the things that we do to attack the myeloma and what to do with that. So this is a quote from the IMWG, which also we talked about this morning. They're really the body where all of us nerds sit in a room and come up with the rules on how should we manage this, how should we adopt this, and really infections is top of the list. It came up with the CAR-T cells, it's true of the bispecifics, it's true of our monoclonals. Pretty much all the therapies that we have are also going to be attacking that immune system. And so not only is the myeloma weakening the immune system, but the therapies are as well. And for better or worse, I think the COVID experience really gave all of us a primer on infection prevention. So things like the importance of hand washing, the environmental control, like mask wearing, really used to be something we had to explain at length. Now it's really a familiar concept. And then things that are more tailored, depending on where you are with the myeloma journey, what therapies you're in, what you're recovering from. there are different guidelines on what immunizations we should do and what other supportive measures need to be in place. But I think generally, whenever you think your doctors are a little bit OCD with fever, this is where it comes from. A fever is your body saying, I'm picking a fight. That's why we also see it with the T-cell therapies, and it's causing inflammation. A fever is defined as 100.4, so I do get calls to say, I'm at 99 degrees. I'm like, okay, keep an eye out, don't take Tylenol, but let's see where that takes us. 104 is a fever. Many times, if your immune system isn't quite up to the task, it may not be able to mount that fever. So when patients are having chills or just not feeling quite right, a little clammy, we want to work that up as well. So we really want all of those symptoms reported. We want to catch infections early and prevent them. The other big one is the kidneys. Again, we mentioned the proteins in the blood have to be filtered by the kidneys, so that can damage the kidneys. The treatments need to be processed and taken out of the system by the kidneys. Getting dehydrated, either because you don't feel well on therapies or because we're just busy and modern life really doesn't allow us to drink our gallon of water a day. And then other medications. You know, a lot of times with the bone lesions, patients will show up with pain. And Advil is most of us' favorite drug. And here we are saying, please don't take Advil, don't take Motrin, don't stay away from these drugs that are really helping you feel better. Similarly, contrast dyes. So the CAT scans that we do, generally we need to weigh the need for the contrast with the CT scans. At the same time, because you have myeloma doesn't mean you can't have everything else. So patients with diabetes, the sugar might damage the kidneys. Patients with high blood pressure damages kidneys. Any other medications you're taking for other symptoms. So the kidneys are really fairly delicate, and I think we've been doing a remarkable job of keeping them safe. And here's a nice long list of things that kind of say your kidneys aren't happy. The one we look for and often see is foam in the urine. That just means protein is spilling. So very common, again, in early days. Fatigue and weakness, because the kidney's job is to be filtering the blood and taking off all of the toxic things. When the kidneys aren't doing their job, you can feel a little hungover. Similarly, the balance of salts with the calcium and other salt molecules, the sodium, the potassium, the chlorides, can be off balance. And if all of that starts to back up and you're not making urine properly, you can get short of breath and the fluid can back up. So fairly non-specific, but things that your doctor definitely wants to hear from. On the other hand, they're the bones. So back when I was in training about 15, 20 years ago, most myeloma patients were wearing braces. So to walk into a room like this and not see anybody in a brace or anybody with a giveaway of myeloma, I think is a huge experience for us. Just like with everything else, we'd much rather prevent it than treat it. So making sure you have adequate nutrition, hydration. Vitamin D is something we monitor very closely. It's something you can be deficient in, but also overdose in, so we want to be diligent. Similarly with calcium, some of the drugs that we use strengthen the bones by getting that calcium from your system back into the bones, and then the blood calcium can be low, so we may need to give patients calcium. Other times we need to make sure the calcium is contained and being put back into the bones. So lots and lots of moving parts. Similarly, once you are feeling well, exercise like weight-bearing activities can really strengthen your bones and decrease the risk of fractures. And lastly, pretty much all patients with myeloma tend to be good candidates for a bone strengthener. And we have a couple different ones which I'll get into in a little bit, but we really are seeing not only less bone damage, like less fractures, less compression fractures, but longer outcomes, right? People live longer when they're on these bone strengtheners. So it really becomes part of that holistic approach to the patient. Which gets back to pain management. Pain can be so complicated. When it's a bone disease, an injury, a fracture, that's really focal. Those are the ones Dr. Joe was saying you can pick up on an x-ray. But by and large, we don't see things on x-rays. They're not such focal things, and they can be so complex. Neuropathy, again, from things like diabetes and other diseases, from the myeloma itself, from the drugs that we use, is a completely different type of pain that can feed into the global experience. The bony diseases, and again, lots of words on the slide, but things like shingles. I have a number of patients who have delayed neuralgias, right, from a prior experience of things like shingles. So figuring out what is the cause of pain and how to keep it under control, I think, is a huge challenge. Most of us will have partners in pain management clinics because treating the myeloma is only a part of it. And again, trying to prevent it, preventing the bone injuries, preventing the neuropathy by changing our treatments, really, really a high priority for all of us. That's sort of just background on myeloma. I know you know all of this, and we've come up with some of the cool new things in myeloma, but what about newly diagnosed? Luckily, even though we have these tons and tons of new treatments, most of the debates and the gray areas and how many transplants to do and when to move CAR Ts up are in the relapse setting. There is generally a consensus that we first start with a combination therapy, so induction, that first treatment that we're using to try to get the first remission. Maybe slightly different combinations, but it's a combination therapy to get the myeloma down. We learned a little bit about the response criteria. We really want to see a 50% reduction. Consolidation is the next level. Okay, the myeloma is in a little bit of control, but we're not happy with that anymore. In 2025, we really want these very deep responses, which will then translate into very durable responses. So consolidation is a second part of usually more intense, short-lived therapy to get the deep remission. And lastly is the maintenance. So we've learned over time that myeloma left to its own devices will keep trying to come back. And so once we've gotten that deep remission, let's try to make it last as long as possible. And usually we did that with drugs. And this whole phase of CAR T therapies, part of the excitement of the one and done is that we're finding ways of maybe having these long remissions without a maintenance therapy. And maybe with the bispecifics, in the limited duration, we'll also be able to cut that back. But for now, this is the paradigm. We push the remission down as far as we can and make it last as long as possible. So there is little debate. Of course, you get 3 doctors, you will always get 5 opinions, but in general, we at least agree that a combination of these 4 buckets is how we should start myeloma. Most patients can tolerate a 4-drug combination. We may need to adjust the schedule, we may need to adjust the dose, we may pick different members of each bucket, but a 4-drug combination is usually the way to start. Few exceptions, we may drop one of them and do the 3-drug combination, and we may switch out partners if we're not getting the response that we want. We've heard a little, and hopefully most of you have heard of these and recognized the classes. So the monoclonal antibodies, the daratumumab's been around a long time, isatuximab a little bit newer, but they're both monoclonal antibodies, so we're again using the immune system to fight the myeloma. And they are either injections or infusions in the clinic. The biggest side effect with them is an allergic reaction to the first dose. So we tend to observe you, and we include the steroids because I think was alluded to, it's our favorite drug to love and hate, but we'll get to those last. The second bucket are proteasome inhibitors. So these are drugs that basically make the myeloma implode because it puts a crank in that machinery. And we have, again, 2. The bortezomib or Velcade is an injection that we've had for a longer amount of time. Kyprolis or carfilzomib is an infusion. They're in the same family. The Velcade is the notorious peripheral neuropathy cause. And again, the most important thing is to notify your physician as soon as you have any tingling or numbness, because decreasing the drug is the best way to prevent rather than have to treat. Then the immune modulators, which is the best name ever given to a class of drugs because we really don't know what it does. They modulate After about 10 years of excellent responses for patients, we found some of the targets, and we now have the next generation are called cell mods because, again, we're getting a little bit of a glimpse into the explanation, but a lot of what works in myeloma we can't explain, and the things we explain don't always work. Keeps us humble, which is a very good thing in academics. So with those ones, again, monitoring the blood counts, the risk of infection. So all of the buckets in that yellow box increase the risk of viral infections. So that's another thing to avoid and prevent. The immune modulators are pills. I think most of us have heard of them, experienced them, had the joy of all the surveys that come with all the pills. Not that my average 75-year-old patient is having pregnancy issues, but that's the government working on our behalf. Mostly GI toxicities and the blood counts. So those are the things to monitor there. And then steroids, right? These are the ones that are the least specific, the least fancy. They're a part of absolutely every regimen except CAR-T to date. And they are the ones that cause the most side effects. I know you are all probably very familiar, and we'll spend some time on that one specifically. So not only is a newly diagnosed patient figuring out what is myeloma, not melanoma, what are all of these drugs that I have to take? Now I want to protect you from all the harm that I could cause with the drugs, and we start all the supportive medications. So the combination of an IMiD and a steroid can increase the risk of blood clots, so we want a blood thinner in place. The antibodies and proteasome inhibitors increase the risk of viral infection, so we start viral prevention. And the steroids, mostly the one that we can prevent, are the stomach discomfort because it really can alter the acid production. So something to protect your stomach, and then the bone regimens separately. So here are a few of the toxicities that we can attribute to steroids. I would say irritability, the mood swings, the lack of sleep, and the desire to eat every sugar-containing item in the house are fairly universal. Yes? All right. Has anyone not had a side effect from steroids? Good, good. So you're taking your medications properly, I'm glad to see. Others are a little less common. You know, cataracts, depending on how much and how long, muscle weakness, cramping, a lot of things that we maybe see with steroids when they're given daily are part of why we've split up our dosing. We actually consider 40 milligrams of steroids a low dose, which, please laugh because I think it's an absurd thing to say, but that's because the studies comparing it to what we used to do was 40 milligrams daily, 4 days on, 4 days off. That was a therapy for myeloma, was just steroids. So when we say we've come a long way, we really are celebrating all victories, great and small. Over time, also, again, water retention. Not only are you eating everything in sight, you're retaining water, everything is uncomfortable, and blood sugar control, absolutely. Again, diabetes happens in the same age range and patient population, so we tend to wreak havoc on blood sugar control. And not only Dr. Joe, there have been several groups, both in Europe, in the US, small institution, big cohort studies, really seeing how can we get away with less steroids. I think universally now, we should all, as physicians, we need to start off strong. The idea is to get that myeloma response quickly, and it's the beauty of these 4 drug regimens is most patients will hit that response definition within 2 to 4 months. So once you are into a response, partial, very good partial, however the depth, let's cut back on the steroids. So decrease the amount and then do away with it altogether. So I have had patients who are in a community setting and their maintenance has been steroids and they've been on just weekly steroids for years. I definitely would like to stop any such practice. So what can we do about it? Again, one of the things, I refer you to our nursing experts, very, very good at specific plans for each of these. We have, again, great nurses, great nutritionists, and then again, how do we prevent some of the things? A consistent schedule is very important. The day of steroids, you don't want to go to bed till 2 in the morning. The next day, you're in bed at 7 p.m. That's a lot for the body to get used to. So in as much as possible, try to have a regular schedule. Take it with food. Take it with preventive medications to protect the stomach. And again, some of my patients do well with melatonin or other sleep aids. Depending on what part of your experience is being disrupted, we can target those specifically. So don't keep it to yourself. Tell us the harm we're doing so that we can then help. The other is peripheral neuropathy. Again, I'm very glad that in general we're seeing less of it because we have alternatives. We have treatments that are maybe not as likely to cause neuropathy. But the biggest intervention that we have is to stop the drug, decrease the dose, decrease the frequency. Because once that damage to the nerves is there, it's very hard to reverse. And when it reverses, it tends to take a really long time. Usually starts with tingling or numbness, fingers or toes, can go on to becoming prickling sensations, sensitivity, and eventually even muscle weakness. So mostly a little bit of numbness. You know, our nurses are always asking before each dose. As soon as we identify it, we cut back and maybe remove it. The other thing is all these lessons we've learned over time. Bortezomib used to always be given twice a week, and now we mostly give it once a week. And it used to be intravenous, where you're getting a much higher dose. Your cells are seeing a much higher dose than the subcutaneous, where it sort of slowly eases into the system. I probably have about a 20% success rate with any of the given interventions, such as the B vitamins. I have patients who do well with pickle juice, with quinine. Every therapy works about 1 in 5, and I don't have how to predict or which ones work with what, but there are a few things that we've learned how to do in between. And there are, again, similar to the diabetic neuropathy medications that we've borrowed, and those also tend to work probably less than half of the time. So we really want to identify them quickly and do as least damage as we can. The next is blood clots. We've really mostly, again, these deep vein thrombosis, DVTs, which can then travel to the lung and become pulmonary embolisms. These are the big bad clots that we really want to avoid. And in someone who is otherwise healthy, going about their business, going to the gym, that risk can be mitigated by a baby aspirin. But if a patient's mobility is being affected by the myeloma and they're not really getting out of the house and they're not moving much, maybe they're smoking, other factors, other medications that can increase that risk, they really should be in a higher level of protection with a different blood thinner. So what blood thinner accompanies the regimen really should be personalized to the patient. And anything that we can affect, like increasing mobility. Some of our patients come to attention because of a spinal fracture or a damaged bone. In time, with treatment, as the myeloma goes away, their functional will get better, so we can adjust as we go. Similarly, if they're recovering from surgery from these original presentations, things like smoking, obesity that we know increase the risk are modifiable. Things like a family history aren't, or maybe a history of a blood clot before their diagnosis of myeloma. So those are things we would probably just keep the patient at an elevated level of protection. Things like exercise and the compression stockings, we really have seen a lot of benefit. Again, recognizing that you're already starting the myeloma therapies and these other preventive therapies, limiting the amount of medications is always good. And adjusting for specific activities such as long flights and travel, where we really want you to be exercising, moving. I think drinking a lot of water is perfect because not only are you hydrated, but you're frequently walking up and down the aisles. So that's, to me, the most effective way of DVT prevention. All right, so that's induction. We start a therapy. As of today, stem cell transplants are still the standard of care for patients who are eligible. I think that may be changing some of Dr. Cole's data on that CARTITUDE 5 and 6, hopefully really doing things that are not quite so toxic, so we don't need to beat you guys up too much. It's not my favorite thing to do, but they tend to work really well. Again, we were talking earlier about tandem transplants. I think that's fallen out of favor now that we have other options, but we really do see phenomenal remissions. So for a patient who is eligible, who's had a good response to their induction, the next step would be this consolidation with stem cell transplant. And believe it or not, stem cell transplant is just the shorthand. It really should be called high-dose chemotherapy with stem cell rescue, because it's the chemotherapy that's treating the myeloma, not the stem cells. The stem cells are just a way of expediting that recovery. And I forget now, I think Dr. Joe was mentioning, like the high-dose melphalan is very effective, but it really wipes clean the entire bone marrow. It reboots the entire system so that the new system can come in fresh and free of myeloma. But left to your own devices, it would probably take about 2 to 3 months for that white count to return. The stem cells repopulate, set up shop, clean up all the damage, and start up this new immune system. It is a lengthy process, and it does require a specialized center. So we first have to make sure the patient is optimized, right? We want to increase the chance of success and decrease the toxicity. So what can we do to make sure the myeloma is in good remission? The other comorbidities, say they have a heart disease history or diabetes, everything is tidied as best as possible. We make sure the heart is functioning, the lungs are functioning. There's no hidden infections that are going to creep up once we decrease the immune system's ability and presence. So a few weeks of getting everything set up. Then the transplant itself, that's, again, 1 day of chemotherapy usually. The next day you get the cells, because the chemo just comes, cleans everything up, but all the cells that are there are still around. So many times patients are like, I think you did it wrong, because they don't notice anything the first day or two. But as time goes on and all of the cells that are circulating start to retire, there's nobody there to take their place. And really it takes about 5 days. And usually I say, if on the 5th day you feel like you got hit by a bus, go ahead, blame me, I did this, but it will pass. So these are the times where most patients would be in a hospital. A few of us do outpatient transplants in the right circumstance. But for about 2 weeks, while these new cells set up shop and clean things up and start making cells, the risk of infection is very high. As we were saying, all of the parts of the armed forces are out. We call them neutrophils and lymphocytes, the T cells, the B cells, everyone that you've been meeting today are all out. So the risk of infection is very high, and should someone try to get a fever or an infection, we want to be there to start a therapy within minutes, not hours. It's also the time where you might need transfusions to keep the red cells and the platelets. I've never seen rosé cells, but I will probably have to take that up now. Platelets and red blood cells can be transfused. The white cells, we need to wait for the machinery to kick in. About 2 weeks later, the cells are there. They're idiots. I kind of equate them to newly minted doctors. You know, you finished medical school, but you haven't actually done the job yet. So we're grateful they're there. You can go home now, but please avoid germs. So this is this post-transplant phase where we ask you to not eat certain foods and not interact with other people and all of that mask wearing and hand washing. And really, it's just recovery. So the 3 months of a transplant are 2 weeks intense, 2 weeks getting better, but really 100 days for you to feel 100% yourself. And hopefully, usually at that point, the myeloma is gone and we can't find it, and we can graduate to just maintaining that therapy. But melphalan is an old school drug. It is not specific. It doesn't have any of the targets. It doesn't see any of the pretty little flags that we showed on the outside of myeloma cells. It will kill any cell that's dividing rapidly. So usually hair follicles fall under that category, and the hair loss, like this is the one time you can't hide having myeloma, but it will pass, and by day 100, most patients have a nice little fuzz recovering. The other is the GI system. So not only are your GI cells always replicating very quickly and replacing themselves and sloughing off and getting replaced, but about 80% of your GI tract is actually your immune system. This is where your body interacts with the outside world. Everything you put in your mouth could be dangerous. So your immune system is all through your GI tract. And when you get melphalan, all of those cells die off in a very, not a pretty way, we will say. Usually I equate it to a sunburn and it just peels. So it can start off as constipation, which is very tricky because for a few days, the pendulum swings way too far over here, and then the chemo kicks in and it swings way, way, way over there. Again, you're in the hospital. Make use of our pharmacists. Take all of the supportive medications that we can give you. Mouth sores tended to be very common. We now have ice chips. So the one thing with minimal side effects, ice chips have really saved the mouth part, but we can't put ice in the whole GI tract. So hopefully getting some nutrition's gotten better. I think definitely from the physician's experience, patients seem to be doing a lot better, but definitely recognize a really, really big torpedo to the GI tract. So staying well hydrated and finding soft foods. This is the one time where I really tell people, if you want ice cream for dinner, that's fine. You get away with it. I just need calories. Because the crazy thing is this is where we're asking your body to make this whole new immune system and do all of this work, and it doesn't want to get any fuel. So really, really important to take care of all of that. All right, newly diagnosed, we're in remission, we're on maintenance. Maintenance is mostly GI as well. It lasts for a good amount of time. We have some data expecting, again, the 7 to 10 years of that first remission for at least a certain population, making that progress. But we know that given enough time, myeloma will continue to try to come back and eventually may relapse. This is where I think the chaos and the Wild West has started in myeloma. Because, again, you've learned about the precursor lesions. They peter until some point they decide to become myeloma. We treat it, we get in remission. We don't know how long it's going to last. We expect there will be a relapse. We're very good at getting that next remission, try to make it last, then it doesn't, another relapse. So I have patients who've done this 17 times. Like myeloma comes, myeloma goes, myeloma comes back, and we continue to find ways of it becomes almost like a whack-a-mole game. So just to sort of highlight the point, relapse is not the worst thing. It's annoying. It definitely requires a lot of work, but that relapse space is full of really promising options. And so really an encouraging time for the space. That being said, I think you've seen some of these in more colorful slides, but there are so many new drugs and so many ways of putting them together. I think the difficult part is how do we decide which one? And I love the way Dr. Joe was saying this morning. It really is a complex conversation. I think it's up to finding the right fit for the right patient at the right time, because even for the same person, 5-10 years apart, their priorities may be different. The myeloma will have learned how to be wise to things that we've used. We know as physicians that certain things should go before other things because they will work after this one, whereas this one may not work after. That's where our expertise comes in to say, these are the options we have. This is why I like this one for you, and then really use that to be a conversation. All of these have very good efficacy to varying degrees, again, depending on their partners, but they also all come with their own panel of side effects. So keeping in mind, maybe if you have two combinations that work equally well, it's the side effects that we're trying to avoid that will ultimately help us make that decision. And as we saw earlier, clinical trials. So for most times when you get to that fork in the road, it's like, okay, the myelomas come back. What are my options? We will have standard of care approved things, and we will have clinical trials. So finding out, again, of that increasingly large menu, what's the right fix? And then lastly, since this has now been covered, but these are the new kids, they've really become pervasive, especially in this relapse setting. Many patients have had everything, and they've now been exposed to a lot of these T-cell redirection therapies. But the therapies are also moving in sooner and earlier in the path. We've learned this across the board. Pretty much every therapy we have for myeloma, we start studying it in patients who have no options, and we move it forward. And when we know it works in someone who's been exposed to 17 other things, someone who's only been exposed to 5 may do even better, and that frontline patient will do even better. So our hope is that even though these are super cool and we're getting these 100% response rates, the responses aren't lasting indefinitely. So we're still working. But also the approved drugs that we have are just that first generation. We talked a little bit about different targets, right? The commercial CAR T we have are all BCMA targeting. The T-cell engager are mostly BCMA and one GPRC. But we have CAR Ts for all these different targets and some that I still can't pronounce. We have T-cell engagers to many different targets. We have now the combination of two targets on the same, either CAR T or when it's a bispecific, it's now a trispecific. And we also have these different manufacturing. I think what Dr. Cole was saying about the in vivo CAR T, we're not there yet. We definitely have some fine tuning to do, but a lot of these new technologies are going to improve access, availability, and timing in a way that's really unprecedented. The other, in the CAR T space, a lot of the delay is we need to collect a patient's T cells, engineer them, and bring them back. We also have certain products under clinical trials at the moment that are made from a healthy person. So a healthy donor can make about 1,000 CAR T doses. And that combines the off-the-shelf immediate availability of a T-cell engager with the one-and-done approach of a CAR T. So maybe that will be the answer on this immediate, accessible, make it available to everybody way to go about it. So many new directions to use our new toys. And a lot of it also, again, as far as the toxicities. Whether it's CAR T or T-cell engager, that BCMA target is a huge part of the immune system. Not only the plasma cells, but earlier members of that lymphocyte lineage. And so that's where this high risk of infections really comes in. And most patients, we were talking earlier about the side effects of CAR T. I think for cilta-cel, most patients go well beyond 12 months of needing IVIG. Around 12 months, some of them may not need it or not need it monthly. With ide-cel, which we also have, it's a little bit shorter, so maybe between 9 and 12 months, patients get independent of the IVIG. And with the new different targets, that may change again. But for now, most of the CAR T support and side effects is just the risk of infections, keeping the IVIG for the immunoglobulins, acyclovir or valcyclovir for the viral prevention, other things like a PJP pneumonia, which is a fungal pneumonia that when your lymphocytes are low, you could be susceptible to. So it really requires a little attention. With the T-cell engager similarly. And then very specifically, again, we talked about the CRS and icons. This is the inflammation. We are asking the T-cells to come and pick a fight. So we want inflammation. We want them to come and, riot, but we want it contained and only on Main Street. So CRS, I usually think, is when the rioting gets out of control and we start to damage the bystanders. Luckily, in the early days, we're like, oh, no, this is inflammation. We want the inflammation. We couldn't possibly do anything to quiet that down because we were scared. Our CAR Ts were so precious. We didn't want to damage them. Steroids could damage T cells. Now we've learned we can actually completely stop the toxicity without having any effect on the efficacy. So one of the major differences in the last 5 years, even when looking at data from the clinical trials, I'm like, wow, that was a lot of the CRS and neurotoxicity, is early intervention. So we used to wait, okay, you had a fever, but you're still breathing okay. Oh, your oxygen, okay, I'll give you some oxygen. Oh, now your blood pressure's low, maybe we'll treat it. Nowadays, our practice at Sinai is you have a fever, you touch that 100.4, you get the antidote. So very early intervention, very minimal toxicity. The ICANS is really the inflammatory. So in that time of great inflammation, if the brain are involved, we call it ICANS, and the antidote is steroids. Again, a short course of steroids works very well. In the early days, you'd walk in, see a patient who couldn't speak, give them 12 hours of dexamethasone. By evening, they're fine, have no memory of it, so the doctors are scarred, but the patients are fine. But we've really learned a lot on that early intervention. And the other is prevention, right? We always prefer to prevent toxicities than try to mitigate them. And things that we've learned are things that increase your risk. So coming into CAR-T or bispecific with a lot of myeloma, you're going to get a much bigger fight, right? We're not surprised. So doing what we can to decrease that amount of myeloma and let the CAR-T pick a more contained fight has drastically increased all of these toxicities as well. Similarly, we can watch the T cells expand, and shutting that down when it's happening too fast, really doing away. So a very, very steep learning curve for us physicians, and really changing our experience pretty much in real time. And so here's some of the infection mitigation, not to give you guys a medical school lecture, just to say there are many different ways of going for each of the deficits in the immune system. So whether it's from viruses, which are mostly T cell related, bacteria, which are mostly these neutrophil type white blood cells, the PJP, which are the T cells, making sure that we're getting as many immunizations as possible. We had a lot of data, and COVID again gave us this opportunity for learning, where myeloma patients, since your plasma cells that are the ones that are responsible for generating a reaction to vaccines, tend to not be working very well, right? The bad plasma cells are keeping the good plasma cells in check. Level by level, one vaccine may not do the job, but we've shown that repeat dosing will increase that protection. So definitely, as long as we avoid live vaccines, because those can sometimes misbehave, really intervening quickly. And the other is this injection, which most of you have probably experienced, certainly those of you who've been through a transplant, the GCSF, which has many, many different brand names, increasing the white blood cells, also is kind of an inflammation instigating drug. So we didn't do that for the first couple of years. Now we do it liberally, and we've really, again, improved our rate of infection. So a lot of good things. The last is weight loss and symptom management, certainly across the board, starting with our very old school chemotherapies, such as melphalan that we use for transplant. The other end, the steroids, which really make you eat everything, retain fluid, and gain weight. But also with the new toys, specifically the GPRC5D that we were talking about. I think it's fun because it's called an orphan receptor, meaning we've looked and we don't know what that molecule does in the world. And it's really not found almost anywhere else except in myeloma cells. So I think it was meant to be a myeloma marker. That's its function in the world. But unfortunately, it does find itself in taste buds and skin. So we saw some of these pictures this morning. I will show you a couple more, and we like our fancy words. So they're in the purple boxes, but they're translated. Dry mouth, dry eye really makes it hard to eat. When your taste changes and everything tastes like cardboard, and your doctor's saying you really got to eat a lot and maintain your weight, much, much easier said than done. Similarly, dental care, when you're not making that much saliva, your mouth can become just a petri dish. If the dryness goes down the throat, swallowing things can be difficult. So with GPRC5D, many times things like meat can be very hard, but things like soup can be easy, or gravy, or sauce. So working with our nutritionists have really helped us learn what are easy foods and what are ways in which to work around and circumvent some of these toxicities. But again, kind of a new side effect profile that we hadn't come across before. And then these classic nail changes, which most patients say are not painful, they're just really, really unsightly. And they will sort of be replaced by a new nail, but that's a very slow process. As with everything else, prevention is key. And I think, shout out to Donna, who really led the charge in establishing guidelines on how to mitigate a lot of this with our clinical trials. So make sure to ask the expert all about it. Moisturizing skin and nails to prevent these rashes and peeling from getting very advanced. And then mostly from the physician side, being okay, decreasing the frequency, decreasing the dose, especially because the bispecifics, similar to that loaded antibody that we were learning about, really tend to do well after we stop the therapy or have to hold it. the response can continue for a long time. And with these drugs, sometimes I now have patients who are 1 or 2 years out from their last dose, still in remission with no further dosing. So a lot for us to learn on how to play with all these new toys. And with that, I thank you for your time.